like, no, Mom, you woke me up 3 times last night complaining of these people coming through the wall. Or, you know, Mom, you were yelling. I'm saying Mom, and I'm sorry. It's just, Dad, you were yelling at a pile of laundry the other day. Okay, in asking, you want to just ask, what are the psychotic symptoms? When do they occur? Has the person had psychosis in the past? It's really important, okay? They've always been a little weird, or, I'm sorry, they've always maybe had delusions or seen things. You're going to say, all right, maybe they had undiagnosed schizophrenia, or maybe they had diagnosed schizophrenia. If it's a new onset, suspect medical. You want to suspect a medical reason right away, or first, because that's usually the case if it's a new psychosis. Ask about that because you want to see if it's changing cognitive abilities, and a psychosis could suggest a comorbid dementia, or possibly delirium. Change in personality. That's always important too. Yeah, we got all this. You want to get medications the best you can, because again, one of the common reasons is medication interaction. Brain imaging, being great. Rule out delirium because it's possible real problems there. We already kind of went through this. Google Capgras syndrome and reduplicative parakinesia. I won't go into them now, but they're really cool. And I'm sorry, not really cool, but just wow. You think your loved ones have been replaced by aliens. The other one is you think someone's come in to your house and completely created a replica, but it's not really your house. I don't know. Right. Figure out if there's been a prior dementia diagnosis. I don't know if you know what the mini mental status exam is. It's usually given in the ER. Not great for diagnosing dementia, but unfortunately, we get called in to do neuropsychological testing. It's really hard to do that with an actively psychotic patient. Really difficult. It will throw things at you, in fact. Happens to be naturally. But it really produces invalid test results. This is not going to be a good indicator of whether or not someone has a dementia. So you really want to test them all when they're stabilized. My point. Okay, so treatment. This is the second to last slide. Goal is to prevent. Hey, it's like not showing. Really fixed. Sorry. Goal is to prevent a psychotic relapse. Duh. You really want careful consideration of any medication given. Antipsychotics, especially the typical ones or the older ones, really have severe side effects. Including tardive dyskinesia, which in some cases can't go away, and it's just like this sort of moving your jaw back and forth, and it's very noticeable having seen that. I'm going to take a whole course of individualized approach. You need to address the environment. You know, talk about caregiver. It's all on the next page. Yeah. Oh, and adapt to specific cognitive deficits. You just want to get some predictable settings, like things like a schedule, sort of a routine. There's restlessness and sort of agitation. Sort of actually distraction works well. Simplify environment. Get the person to do as much as they can on their own. That's really important. All right, maintain what they have. Yeah, just try to get down the too much noise, overcrowding, and monitor progress. So, final words. Overall, want to point out it's pretty rare. Okay, in the community level, seniors really rare. This is much more of a public health concern. But still, most seniors are just fine. Yeah. Okay. Yes.
I have 2 questions.
Okay.
So do the symptoms of schizophrenia, do they decrease with age or become worse or stay the same?
Great question. Actually, it's thought that they actually decrease.
Can you say the question again?
Okay. Do symptoms of schizophrenia get worse with age or decrease with age? And they actually are shown to decrease with age.
All of them, even negative, positive, and cognitive?
Negative are less. Good question. But yeah, like in general, especially the.
But not cognitive. That doesn't.
They're still having. There's basically, it's not completely known why, but the severity, I guess, the scope of the delusions, the frequency of them, of hearing voices and stuff, are thought to diminish to the point where, they're still generally on medication, but they can decrease their dose, or maybe that's because the dose is working better. But actually, even when they decrease their dose, it's still. So I'm not sure. I don't know if you have any added. But yeah, stuff. Yeah, it really does. I mean, it's maybe they're coping with it better. It's hard to know. I mean, this is a really young area of research. Honestly, it changes like every 5 years, even the medications used. So, but yeah.
So let's suggest, actually, we take a break, and if people want to grab Jessica for a couple of questions during the break, feel free, and try to come back like a couple minutes after, a quarter after, so we can pick up again. And thank you.
Oh, yeah, sorry.
Yeah, thank you.
Yeah, last thing you
topic, probably more prevalent. So I'm going to talk about anxiety disorders, particularly in older adults. I'm going to start by giving you an overview of the latest, so the DSM-4 anxiety disorders. You've probably heard of most of them, the major diagnostic categories, so panic, the two phobias, obsessive-compulsive disorders, OCD, that you hear a lot about in the media. PTSD is post-traumatic stress disorder, and then generalized anxiety disorder. There are also the lesser-known categories, such as acute stress disorder, anxiety, just like what Jessica talked about with psychosis, due to general medical conditions or due to substance use, and the NOS category. So for anxiety, an example of anxiety disorder NOS would be mixed anxiety depressive disorder. So for instance, someone who has clinically significant symptoms of anxiety and depression but do not meet criteria for a specific mood or anxiety disorder would be diagnosed as anxiety disorder NOS, so not otherwise specified. So quickly going through this, I won't go into depth of the diagnostic criteria of each of the disorders, but I will give you kind of the hallmark feature of each of these conditions. So for panic, it's characterized by someone having recurrent unexpected panic attacks, and the person has persistent concerns over additional attacks or the consequences of having these attacks, such as, oh my God, I'm having a panic attack, am I going to die? I'm going to have it in public, or what are other people going to think of me? I'm so anxious about it. It can come with or without agoraphobia, which is the fear or avoidance of situations where panic attacks might occur. So people not wanting to go to the mall or going to the supermarket because thinking that if I go to the mall, I may pass out there from having a panic attack. Sociophobia is characterized by strong fear or avoidance of social situations because the person thinks that he or she may be severely embarrassed or humiliated in those situations. So think of someone being extremely, extremely shy and fearful of, say, social evaluation or social interactions. And then we have the specific phobias. There are specific types of things that people are fearful of, such as animals, natural environments, of seeing blood, of being injected, of having injections, or seeing injuries, or seeing surgery, bloody surgery going on. It can also be situational. So some people are scared of enclosed space. There's also the interesting space phobia.